Thank you Indonesia.
Cinta satukan hati, kuatkan jiwa menghadapi dunia. Segala cinta dan duka, kuatkan semua persahabatan.
Tanpamu tak akan sama, tanpamu semua berbeda. Kisahmu juga kisahku, selalu bersama. Kita menatap dunia, dia bersama. Kita akan menang. Kita penakut dunia, dia bersama. Kita akan menang, menang. Oh, oh, oh. Oh, oh, oh. Melangkah di bawah mentari yang sama, mencari tempat kita di masa depan. Berjanji kita tak akan putus asa, walaupun semua takkan mudah. Bersama kita akan menang. Kita penakut dunia, dia dan sawan. Kita akan menang. Oh, oh, oh. Thank you Indonesia.
Cinta satukan hati, kuatkan jiwa menghadapi dunia. Segala cinta dan duka, kuatkan semua
Indra Lesmana, Ms. Maria Constantino, Associate Professor Mark Brown, and all of beloved audience. First of all, thanks to the Almighty Allah Subhanahu wa Ta'ala. Because of His blessing, we are able to come here to join this online seminar meeting by Indonesian Sport Physiotherapy Community in collaboration with International Federation of Sport Physical Therapy. And secondly, salawat and salam also delivered to our Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us from the darkness into the brightness. And well, ladies and gentlemen, the presentation today that are the first session is opening presentation by Mr. Shahmirza Indra Lesmana. The second session is presentation about acute intervention in hip sport injury by Prof. Mark Brown and clinical approach in hip sport injury by Dr. Maria Constantino with two cases is about FAI and the other case is about adductor strain. The third session is question and answer session, and the last session, fourth, is closing and conclusion. Well, ladies and gentlemen, now let's open our meeting by saying basmalah together. Bismillahirrahmanirrahim. Thank you. The next, for the first turn, will be given by the first presenter. Please welcome Mr. Shahmirza Indra Lesmana.
Okay, thank you Cakra. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
All the audience, may I just say hello to our special guest, our auntie and uncle from Australia, Maria and Mark. We call it M&M. Yeah, they are like our family because they always support us for develop the sport physiotherapy in Indonesia. Thank you for coming. Thank you for joining us, and we are very appreciative for you to come to this meeting. May I give the speech in Bahasa so the participant can understand Mark and Maria?
Certainly. Thank you, and thank you for the welcome.
Oke, teman-teman sejawat, kita berbahagia sekali hari ini karena kita bisa mendapatkan pembicara yang luar biasa, Maria dan Mark. Dua-duanya adalah fisioterapis olahraga dari Australia, dan dua-duanya itu adalah orang yang sangat berjasa untuk mengembangkan sport fisioterapi di Indonesia, karena sudah 2 kali level 1 sport fisioterapi diadakan oleh mereka berdua. Rencananya sebenarnya tahun ini kita undang lagi mereka di bulan Juni, tapi karena pandemi ini sehingga kita tidak bisa mengadakan. Tapi saya bersyukur karena kita bisa ngajak mereka berdua untuk mengisi acara pada pagi hari ini untuk mengobati rindu kita kepada mereka berdua. Jadi alhamdulillah hampir saat ini sudah ada 100 lebih peserta, sehingga harapan saya adalah teman-teman mengenal bagaimana Maria dan Mark, sehingga tahu bagaimana kalau teman-teman mengikuti level 1 nantinya. Harapan saya bahwa ilmu yang diberikan dapat memberikan manfaat, dan juga kepada teman-teman yang ingin bertanya nanti silakan tulis di chat saja dalam bahasa Indonesia nggak apa-apa, karena nanti Cakra akan menerjemahkan dalam bahasa Inggris sebagai moderator. Jadi harapan saya teman-teman bisa menikmati acara ini. And once again I would like to say thank you to Maria and Mark for joining with us. We hope this is not the last, but we will see you again in next 2021 to give the level 1 course in an acute intervention course in Indonesia. So, selamat menikmati teman-teman. Assalamualaikum warahmatullahi wabarakatuh.
Oke, thank you Mr. Indra. Buat teman-teman, masukan dari saya kalau misalnya mau memberikan pertanyaan, tolong jangan terlalu panjang, langsung ke intinya saja. Baik, next turn is for the second speaker. Please welcome Professor Mark Brown and Dr. Maria Constantino. The screen is yours.
Thank you very much for the welcome. And thank you for this opportunity to meet you via the internet. It's a new stage of all going, and I'm looking forward to seeing you and feel very close to you, and we always feel very welcome when we come to Indonesia, and look forward to seeing you all next year when we're able to travel again. I hope you're all safe and well, and now we'll progress with our presentation for this morning. We're going to discuss hip pain in sports, as Chakra said, and we're going to be presenting 2 case scenarios for you that we're going to use to work through from the acute intervention, the on-risk return to sport approach. So, as I mentioned before, we're going to really be discussing this scenarios, looking at what we as physiotherapists working on the field may be required to do, and then following up our athletes into the clinic, looking at the rehabilitation and management, and then looking at the graduated return to sport. As we're aware, there are many causes of hip pain, and this here that are highlighted as some of the most common ones on the left-hand side. And on the right-hand side, as well as the in the center, it's important that we are aware about excluding any red flags or any other more sinister conditions that we need to refer on for further management. I'm going to now pass on to Mark, who is going to commence with the on-field acute intervention for case scenario 1.
Thank you, Maria, and thank you again to all of you for the opportunity to talk with you. And as Maria has said, we're very, very pleased to continue our association with Indonesian Sports Physiotherapy Group, and the welcoming that we have had from you in the past has always made it a great pleasure to work with you and share knowledge and ideas, and we've been very pleased and impressed by the good work that's been done by all of you, and particularly those on the committee, to bring forward the development of the sports physiotherapy group, and also the understanding of what is a sports physiotherapist, and what is the difference between those who have a recognition as being a sports physiotherapist compared to those without the sports role. And one of the most important parts is the ability to be able to provide care in the on-field environment, at the field of play, or at the training session, or in the dressing rooms, or whatever it might be, but not in the role in the clinic that many people may be more familiar with. So we've got a couple of scenarios which we're going to take sort of from the field of play through to return to sport. And the first one is, if you can imagine, you're working as a physiotherapist for a football team, and at the game, a 24-year-old male player reports after landing from a jump that he's got pain in the right anterior upper thigh, up in the groin area. He's landed from a jump and he's had a sudden onset of pain, and he was able to get through the last part of the first half. It's now half time and you're in the dressing room, and the coach wants to know if he can continue to play. And you've got 5 minutes before the referee starts the second half. That's all the time you've got to make a decision or a recommendation to the coach. So what do you do? Well, according to the competency standards of the International Federation of Sports Physical Therapy, sports physiotherapists must be able to respond appropriately to the management of acute injury in both training and competition contexts. In other words, in a much more abbreviated time frame and without the equipment or facilities that we might be used to in a clinic. So it is often the case you have to make a decision very rapidly to assist the coach or the player understand whether or not they can continue to play. In some cases, it may even be an emergency, and you may need to initiate emergency medical care. And we've covered things like that in the Level 1 sports course. But today we're talking about musculoskeletal injuries that require a rapid decision-making process so that you can make sure that the person is not made worse by a decision to return to play, and also that you can assist the coach understand whether or not the player has the capacity to continue to play effectively. There's some methods that you can use to rapidly determine whether or not a player is able to return to play. So here we are in the dressing room, says he's saying he's got pain in the groin, can he continue? So we would in the clinic use a similar approach to what's outlined here, but this is much more abbreviated, and it's a principle called the toe taps approach. And the toe taps, as you can see on this left side of the screen, stands for talk, observe, touch, active movement, passive movement, and skills test. So what we need to quickly do is ask the player what happened, maybe establish if they've had problems in the past. But while we're talking, we're also observing the injured area. Can we see any visible deformity? Is there evidence of bruising or swelling? If it might be on the field of play and there's an open wound involved, that's a different thing. But nevertheless, we need to look for any indications that maybe there was contact trauma that has contributed to their problems, or it might be that it's an avulsion of a muscle from a bone or even a fracture. So we're looking to see if there's any obvious signs of deformity. There may not be anything visibly present, so we will do palpation. So we will touch the injured area and we will feel if there's any areas of local tenderness. We'll feel if there's increased temperature or changes in the feeling of the tissue. There may be a deformity that's palpable under the skin that isn't visible, or we may feel swelling, which again is not easily visible. If there's any things that show up in these assessments that suggest that there's a serious injury, then that probably means they're not going to be able to return to play. But if there's no obvious areas of tenderness, there's no deformity, if there's no visible deformity, and we will then progress to determining whether they can move normally. So initially, we'll ask them to move the injured area. So we'll do an active movement assessment. Do they have full range of movement? Is the injured side equal to the unaffected side? If they can move fully, we will then progress to a passive movement assessment and check the full range of movement, including whether or not the end feel is normal, or if they have pain at the end of range. Overpressure might elicit pain even though they don't get it with active movement. If it feels normal to you, they have full range and they don't have substantial pain, we can then progress to a skills test. And we will use a skills test which is appropriate to the sport and to the role of that particular player within the sport. But in this case, we've got a football player and we need to know whether or not he can run, change direction, and kick a ball. So we will progress the skills test, usually going from slow to fast, from single direction activities such as straight line running to multi-directional activities, including sidestepping, zigzag running, figure of eight running, and we'll add more complexity that mirrors the demands of that sport. So, for example, we might ask them to walk. If they can walk without pain, can they run slowly? If they can do that without pain, can they run fast in a straight line? If they can do that without pain, we'll introduce change of direction, such as forwards and backwards running. Thinking about the sport, in the case of a football player, it's very important that they can move sideways. The lateral movements need to be considered as well. So we'll also think about cutting and sidestepping, but also the forwards and backwards, whether they can sustain higher load activities such as jumping and landing. And you'll start again more simple and progress to more complex. Start with a double leg jump, progress to a single leg jump on the affected side. And if they can do all those things, we'll then do some sport-specific drills. Can they kick the ball without pain? Can they run while controlling the ball? If the answer to those things is yes, then they probably can return to play. But in this scenario, while the player was able to complete the skills test successfully, they still had pain with some movements, including kicking. And your suggestion to the coach is that he shouldn't return to play. The coach him to field of play. However, after a short time, after 15 minutes, his pain increases to the point where he can't continue and he comes off. So within the dressing room, you can start the immediate care, and we'll talk a little bit more about that in the second scenario, but we want to make sure that they don't do anything to make the injury worse. So we advise them to avoid anything that's provocative or that's likely to cause additional stress on that area. We don't know what it is yet. We know he's got groin pain, but we don't know the cause, which is why we refer him to physiotherapy clinic for a further assessment and management. And that might be you if you're the team physiotherapist, or it might be one of your colleagues if your role is more in the acute field of play setting. So Maria will tell us a bit what we will encounter in.
So we've got our player now who is coming to the clinic, and we need to, proceed with is, sorry, oh, what did, sorry, this, okay. So we've got the history of the football player. We know that they're experiencing pain with kicking, twisting, and turning when they're playing football. We've already heard that from Mark. And we know that when we asked him further, we found out that he has had a gradual onset of pain over the past 6 months. So the pain has been gradually coming on. There hasn't been an injurious incident. And it started to get worse lately. It started to increase in the visual analog scale to 7 out of 10. We know that he usually trains twice a week and he has a match once a week. He's right foot dominant, so he kicks with the right foot, and that's the foot where he's experiencing the symptoms can account for. So when we look at then the body chart, it's very important then that we look at where the pain is, and we also ask him in terms of if he's experiencing any symptoms in any adjacent joints. And as you can see here, the adjacent joints are clear. He's experiencing intermittent, deep anterior hip and groin, sharp pain, 7 out of 10, but it can develop into an ache. And this is important for us to understand because it gives us a bit more information as to the nature of what might be causing his symptoms. We also ask him about if he's experiencing any pins and needles or numbness, and there's none. He is experiencing clicking in his hips, and he's had a past history of clicking, and he's getting it occasionally now as well. However, no other symptoms in the lumbar spine, in the hip, knees, and ankle. And with lumbar spine, as we said, one of the important things is to exclude the possibility of referral from lumbar spine. With differential diagnosis, then we need to consider the area of pain and symptoms. We need to look at what structures are underlying the area. So in the hip and groin, we look at the anatomical structures. We need to look at also the structures that can contribute or to the symptoms, as well as areas that can refer to the hip and groin, like the lumbar spine, for example. And together with the history, we need to consider the possible diagnosis and select the clinical tests and imaging as required to support or negate our hypothesis. So really we're looking at the history, if there was a mechanism of injury, what anatomical structures may be implicated under the area, what may be referring, look at what clinical tests we're going to use to assess and be able to then look at supporting a hypothesis or negating it. So looking at this framework that was published in 2018 by Christian Thorborg is actually gives us a little bit of an idea as to the best way to approach this. And we need to, as clinicians, and exclude red flags. It's really important that if we're suspecting a fracture, if we're suspecting any the possibility of any tumors or any other sinister conditions, that we refer on for further assessment. We also, as we said before, screen for the lumbar spine and the sacroiliac joint contribution. And then we look at our clinical differentiation. And I'll go through and cover the clinical entities of groin pain, as you can see here in these 5 boxes. But it's important then if we're suspecting, for example, that it's adductor-related or pubic-related groin pain, that we can refer them on for ultrasound or MRI if it's indicated. We're suspecting an inguinal or iliopsoas-related groin pain, and then ultrasonography may be sufficient. Whereas if we're suspecting that it's a hip-related groin pain with the actual intra-articular structures of the hip, then we may need to go to a radiograph and magnetic resonance imaging. And then based on the clinical assessment, the clinical differentiation, and the assessment of the imaging, the outcomes of the imaging, we look at management. So if we're looking then at the main clinical entities of pain, and this is a very good consensus statement that was published in 2015, then it can be separated into 5 distinct areas. The adductor-related groin pain, which can be acute muscle strain, or it can be an adductor tendinopathy as a chronic pain. Similarly, with the iliopsoas-related groin pain, which can be both acute and chronic, with iliopsoas tendinopathy and anterior snapping hip. The Inguinal-related groin pain will include the rectus abdominis tendinopathy, and then the pubic-related groin pain really looks at a pubic bone and osteitis pubic, bone stress and osteitis pubis, as was previously named. And you can see here in this picture the color coding of the different entities, which makes it a lot easier for us to then start to think about the assessment and the palpation. And then the next entity is the hip-related groin pain, which, as published more recently in a review by Rainman and al., entails three main hip conditions: the femoroacetabular impingement syndrome, the acetabular dysplasia and/or hip instability, and other conditions without distinct changes to the bone structure, to the osseous morphology. So that's the more the intra-articular structures, such as your labral tear, ligamentum teres tear, and chondral pathology. And then, of course, the other one is the hip osteoarthritis. So now if we go to the femoroacetabular impingement syndrome, which, as we come and work through our case, we will see that this is what it may be indicating, but we'll work through it. It is actually, the definition for it entails a motion-related clinical disorder of the hip with a triad of symptoms, clinical signs, and imaging findings. It represents the symptomatic premature contact, it says here, between the proximal femur and the acetabulum, as you can see here in these slides. So really, you've got to have symptoms, you've got to have positive clinical signs, and you've got to have positive imaging findings for the diagnosis of femoroacetabular impingement syndrome. And there are three types of morphology that can be seen on imaging. It's the CAM morphology, which, as you can see here, it reduces the head and neck offset, and there is a premature contact between the head and the acetabulum. The pincer morphology, as you can see here in this slide, and you can see here that there's a much more bony growth at the acetabulum, and it's generally anterior, or you can have the mixed morphology. Now, the important thing as well is the to realize that the CAM and pincer morphology that you can see here can be present on X-ray, but it could be asymptomatic. So up to 25% of people may have it on X-ray, but they may not experience any symptoms. That's why it's really important that we also look at the clinical signs, not just the radiographic findings. And it's commonly seen in young athletes, such as our football player here that we can see, in ballet players, hockey, martial arts. A lot of adolescents were loading their hip quite significantly during their growth period. That may be a risk factor for CAM morphology. And they also suspect that CAM morphology has developed mainly when the proximal femoral growth plate is open, and that's when you're getting a slip of the femoral capital epiphysis slightly, and then you're getting the thickening of the head and neck offset. It's rare after the closure of the proximal femoral growth plate. So that is something that then we think it develops in adolescence and then starts to give them problems in the early 20s as they're continuing with some of the provocative movements of kicking and internal rotation and adduction. Now, it's important to also know from this consensus statement that there is different terminology now that is accepted for FAI syndrome. So we no longer can say FAI is asymptomatic or symptomatic. We need to say the full femoroacetabular impingement syndrome. We also don't talk about deformity. We talk about CAM morphology and pincer morphology, which is a much more positive term. And this is what's recommended now in the literature. The clinical presentation of FAI syndrome then will include looking at our symptoms. And as we said before, it's a motion or position-related hip and groin pain, especially anteriorly and deep in the joint. And there may also be clicking and catching and locking. The clinical signs we're going to look at is mainly the flexion, adduction, internal rotation test, which is, I'll explain later how it's used to exclude it. And they may also have limited range of motion in internal rotation. And we talked about investigations. The AP view of the pelvis and the Dunn view will be the best views, as well as looking at further hip morphology and cartilage and labral lesions through an MRI. The other possibility that our football player may also be experiencing is an acetabular labral tear. Now it's important because this is another one of those structures in the hip joint. And the acetabulum is a ring of fibrocartilage that's really deepens the acetabulum for stability. And it has a blood and nerve supply, so it's very pain sensitive. It is one of the most common intra-articular hip injuries in athletes, with up to 22% of athletes with hip pain. And the anterior superior tears, as we can see here in the pictures, are the most common. There are different grades, and the patients with labral tear have a 40% chance of also developing chondropathy, which then can lead to osteoarthritis. So it is important that if we're suspecting labral tear, that we identify it early. The clinical signs, again, is the flexion, adduction, internal rotation may be positive. It has high sensitivity and low specificity. And the Thomas test has both high sensitivity and specificity and can reproduce the patient's pain, but also the click they may be experiencing. So in the recent consensus statement, again, then as a clinical recommendation for assessment with people with hip-related pain, we're looking at the flexion, adduction, internal rotation test as a test that's being used. So if negative, then it can help to rule out hip disease in young and middle-aged active adults. So we need to do then the flexion, adduction, rotation. If it's negative, then it can rule out hip disease. And then we'll go into diagnostic utility, looking at hip disease in people with hip-related pain. We know that X-ray may be limited unless it's combined on its own. We need to combine it with the patient's symptoms and clinical signs. So the AP radiographs and lateral femoral head and neck is recommended best for diagnosis of hip conditions. And then with MRI and CT are recommended where we need the 3D morphological assessment of the intra-articular structures. So this is a very good article that I recommend in that would be very useful to have a look from the British Journal of Sports Medicine, which I'm pretty sure is free to access. So if we go back to our 24-year-old male football player, then with the ongoing hip-related groin pain, what are we doing? We need to then look at the clinical test. We'll do the flexion, adduction, internal rotation test. If it's negative, then we can rule out the intra-articular hip, and we might consider, hip-related groin pain and consider other causes of hip pain. If flexion, adduction, internal rotation test is positive, then we're not sure really. It may rule in a hip-related pain. However, we need further assessment. So we need to then include the presenting symptoms that he's experiencing. So pain with kicking and with cutting and turning. We need to also look at the send him for X-rays to look at the AP and lateral hip views and see what the morphology of the femoral head and acetabulum is. And if we're then the findings demonstrate a CAM morphology, we may then diagnose him with FAI syndrome. However, we may also want to have an MRI or a CT to look at the morphology of the intra-articular structures to see if there is also a labral tear or any other cartilage or ligamentum tears injuries. And so combined together, then that will give us a much better answer so that we're able to manage this athlete a lot better. We must remember also with our athletes that it's important to look at outcome measures. And these are some examples of outcome measures that are very useful for athletic populations, the IHOT 33 or 12 and the HAGOS. And I'm not sure if they're translated in Bahasa. So it's something that maybe Indra might be able to let us know, because it would be useful to, if not, that we look at someone to do the translation. So then looking at managing this case, managing our football player in physiotherapy, because he's presenting with a lot of impairments, we need to look at first of all, our principles of management. We need to look at, is he experiencing pain? Do we need to look at pain relief? Do we need to look at then tissue healing, muscle flexibility, conditioning, neuromuscular control, functional activity progression, and then return to sport? So all of these stages will depend on the stage of injury and disorder, and we'll work through them a little bit more as we get into the next case. But it's important that we exercise a patient-centered approach, that we look at education of the patient, look at managing pain, like we said, managing stiffness and any reduction in range of motion, there's any instability, if they've got feelings of instability, we need to look at providing muscle control and motor control and re-education, taping if necessary to provide some support. Look at addressing any tight muscles or overactive muscles. Look at inhibiting also overactive muscles, and looking at strengthening and building endurance in the muscles that may be weak. And we'll work through those a little bit more. It's also very important that we look at balance and proprioception, starting at low impact, looking at static and progressing to dynamic and more unstable surfaces. Looking at if we need to look at any biomechanical correction in gait retraining, in any of their skills. And then look at the functional rehabilitation, which is looking at higher level strengthening, endurance, functional activities, sport-specific skills, and then looking at loads and training load and games load as they're returning back to sport. And we'll talk a little bit more about that as we are progressing through. So patient education, as I said, it's really important. Without a good education, the patient, our athlete won't understand why we're doing what we're doing, what is happening to them, and they'll be a lot more fearful to actually then progress with their exercises. So we need to talk about the condition, the healing process, and the different treatment approaches so they can make an informed consent. Look at addressing any hip range of motion limitation. And as we said, one of them in FAI syndrome is internal rotation limitation. So if it is possible to address it, then we look at manual therapy and also addressing stiffness. And we can look at mobilization with movement, or we can look at Maitland type approach or Kaltenborn, different type of approaches. The other important thing in rehabilitation, and Mark will talk more about the phases of rehabilitation with the adductor groin strain case scenario soon, but it's important that to be aware that sometimes you might be working across the different phases. So as you can see here in this slide, the green is your primary. So you might be working on regaining active and passive range of motion concurrently with joint stability, which is part of phase 2, and introducing some speed and agility as they're getting more stability as part of phase 3, also generating strength, and then starting to do motor control retraining with ingraining new patterns. So it is important that you work across the different areas of range of motion, motor control, muscle strength, and exercise prescription that might be controlled and introducing gradually more complex movements. So we've talked about this, the importance of proprioception, and about the importance of building muscle strength. We'll go through some examples of exercises. So these are some good examples of exercises to strengthen the abductors, which is going to be really important for our athlete because we don't want them to be dropping into adduction internal rotation and provoking that FAI syndrome, that CAM impingement. So these are the further ideas again for hip abductor strengthening exercises, and then one of the most functional exercises that we can introduce is the squat exercise, which needs to be controlled and with good form, as we can see here in this picture. We need to address gluteus maximus as well as iliopsoas, so we need to address all the other muscles around the hip to provide stability and control. And look at closed chain weight-bearing exercises to recruit the hip muscles more in their functional role. And as you can see here, these are some further examples of hip abductor exercises. We can start to introduce exercises like crab walks as well with TheraBands, and also some of the bridging exercises are very good. And then we're looking at, working with our athlete towards progression to return to sport. However, if conservative management fails, we do need to refer them on for possible surgical options. So the FAI syndrome surgery may be what's required, and they may also require labral tear repair or resection. But however, whether they go for surgery or not, the exercises that we give them and the prehabilitation as well as the rehabilitation afterwards using motor control and strengthening exercises would be very important in preparing them for a better outcome in the long run. So then with return to sport for our athlete, we need to be thinking about the fact that return to sport is not a single time point. It's a continuum. We need to think about returning them to training and participation, then returning them to sport, or maybe that they're playing part game and then returning to performance. And one of the this review article published in 2019 actually puts the functional recovery model really well, where it's looking at our
Maria's having some problems with her headphone at the moment. Just changing a cord there, which will be back shortly. There's a couple of questions. Okay? There's a couple of questions that have been posted in the chat, including about the importance of training hip mobility for younger athletes. Some of the slides that are coming up will talk about this a little bit. And also about the importance of biopsychosocial factors, which are very important in athletes as they are in all people. Athletes, like other people, have different experiences of pain and different understanding. Maria's already talked about the importance of patient education or athlete education. Very important, particularly in the sports setting where there can be a lot of other psychosocial factors, including the desire to get picked for a team, etc. But we might not have time to talk about that much more. Maria's ready to go, so I'll mute and have.
Yeah, thank you. And in fact, for the questions, we welcome the questions, and Chakra will be collating all the questions at the end, and we'll have some question time and address all of you, as many of the questions as we can. But thank you for that. And my apologies, my headphone decided to need recharging. So as I was saying before, the rehabilitation phase, that's the phase that we're working with in the clinic. But you can see then also that as we are progressing the return to sport, we need to be thinking about on-field rehabilitation as well. And there's a crossover period of where they're rehabilitating in the clinic, but they're also returning back to the field and training and doing some of their rehab as part of the on-field training and preparation with their team, but using specific exercises for their, And then you look at then return to training phase, where they're starting to train more formally with their teammates, and then looking at the more competitive match play, but they may not be playing the whole match. They may be playing part of it, and then returning to performance where they're really returning back to being able to play fully like they used to before. And the length of each stage will vary depending on the injury, and this is relevant for any athlete returning to sport. So we need to then think about then returning to training and returning to sport. We can start the skill retraining and proprioception, like we mentioned, and also ensure that we retrain more high-level skills and balance. And incorporate landing techniques that are going to be necessary, looking at good control around the pelvis and good form, looking also cutting and turning techniques and ability to react very quickly to quick decision-making without any symptoms. There are also certain hop tests that we can use to test their ability to return to sport, and looking at symmetry index between affected and non-affected side. And this hop test looking at a hop for distance and time, as well as crossover hop, and looking at the deficit from side to side. So then we're looking at returning them, as we said, to training, sport, and performance as part of that continuum. But however, we mustn't forget the importance of injury prevention as we're returning them to sport. And with our football player, we need to consider some of the FIFA 11 plus exercises. And this is freely available. This publication was also as part of the British Journal of Sports Medicine. But you can see that there's graduated staged exercises that you can use to be able to introduce sport-specific skills and injury prevention programs for our football player. I'm now going to pass on to Mark to discuss case scenario 2.
Thank you. So with the case scenario 2, we're going to look at a slightly different situation where we have a basketball player. There we go. And in this case, the basketball player reaches for the ball while changing direction and gets up slowly and holding his upper thigh. He tells you that he felt a pop sensation high in the groin, and he now has 6 out of 10 pain. He can walk, but it increases with weight bearing. And in actual fact, this describes fairly closely an injury sustained by a very, very famous player, LeBron James. And we're going to run a video now which actually shows a similar scenario to this and how the medical staff assess him on the field of play, which is what our focus will be this time. So is the video ready?
Unfortunately, we have to look at the ad.
So we're just using a YouTube clip, and unfortunately that means it's going to take a little moment to load, and hopefully, no, we've got an ad. This doesn't look like it's the right page. Skip ad, there you go.
Oh, skip ad.
Yeah. Okay, sorry about that. They didn't even pay anything for that advertising privilege. So you can see the player's gone down, LeBron James, as those who follow basketball will know well. And he's then holding up into the groin, and you can see what he says to the trainer. They say, what happens? And he says, I felt a pop in my groin. And you haven't got the audio there, but you actually can hear him say it. And here's the slow motion. It shows here a very typical thing for muscle injuries, which is it's occurring from an eccentric phase of movement to a change of direction involving concentric muscle activity, but with additional force as a result, in this case, of his foot slipping outwards. And as a result of that, the adductor muscles are put on a lengthened position. They're still contracting both eccentrically and then moving to a concentric phase, but as the muscle is being forced to do an elongated position, the muscle fibers fail. So the trainers talk to him, and in a little while you'll see that they ask him to do some different sorts of range of movement exercises. You can see again, not very well because the buffering on the video is not very good. But they ask, can he do a double leg squat? What happens when he does an external rotation? And one of the other pictures also shows him doing some adductor stretches, but he's unable to continue and he walks off the field of play. Okay, thank you. So let's put ourselves into the shoes of the physiotherapist there. You're the person here in the picture who has to make a rapid decision as to whether or not he can continue to play or he needs to leave the field of play. So for the on-field assessment, we usually use a principle called the STOP principle, which is used to quickly identify if an athlete needs immediate care or if they can remain on the field of play. And STOP stands for, first one, stop the game, stop the player from moving, in case they're going to make themselves worse, and then talk to them while observing. It's similar to the toe taps in the talk and observe, but this is much more rapid. We might only have, depending on the sport, 10 to 15 seconds, rarely more than 30 seconds to make a decision. Ask them what happened, what did you feel? Ask them if they think they can play on, and at the same time, note through your observation, are they in severe distress? Can you tell from the way they're talking or from the way they're holding an area that they're in severe pain? They might, because athletes often will want to continue, they'll say, I'm okay, I can keep playing. And you can see, because there might be some visible deformity or that their pain level is very high, that they really can't. But once again, we're looking for obvious signs of injury, such as swelling or deformity. Can they move the injured part? And if they say they can play on, you can't see any obvious signs of deformity or injury, and they want to continue, then maybe you'll do something to prevent further injury, such as quickly putting on some tape or a bandage to provide some additional support to get them through to the end of the game or the end of that section of the game. So that's the STOP principle very quickly. But in this particular case, using that sort of approach, and the STOP principle, sometimes you may even put a little bit of a skills test in there. If you're not too sure, you might ask them if they can jump or land. And if they can't do that, then they'll have to come off. And in this particular case, with LeBron James, he wasn't able to continue to play. So he was removed from the field of play. And what we should do is start treatment as soon as possible. And what does treatment involve? Well, there's different phases of treatment. We have the acute phase treatment, where we can start rapidly initiating some of the police principles, as we usually refer to them now, which is protect the person from further injury. We might put them in a brace if it's, say, a knee injury, or in this case, the groin. There's not really many suitable braces, but we may put them into some compression shorts or use some tape to provide some support. And if it's a muscle strain, there's box deloading tapes and other sorts of taping techniques that might be appropriate. Or if we want them to take the weight off it until it's assessed further, then we may use a walking aid like crutches. Right from the outset, we want to think about optimal loading of the damaged tissue. In the acute phase, the optimal amount of load is low or none, and as they start to improve, we will gradually increase the loading. But in this acute phase, the first 24 to 48 hours, it will be essentially rest from any provoking activities. We may use ice for pain, and according to some people's thinking, maybe also for minimizing bleeding or inflammation, but we need to be careful about that because we don't want to inhibit the inflammatory process, which is a necessary part of healing. But we can also use compression and elevation to minimize bleeding and inflammation in the area. At the same time, we want to avoid any aggravating factors, which are sometimes summarized in the abbreviation HARM, which is we don't want heat in the acute phase because that can increase bleeding through vasodilation of the blood vessels. Similarly, alcohol, which opens up the blood vessels, can increase bleeding, and so will running or any other form of excessive activity in that acute phase. And similarly, massage is contraindicated in the acute phase because it can further the damage to already traumatized tissue and also potentially increase increase circulation, which will contribute to more swelling. So we initiate the police factors and we avoid the harm factors, but we also know we want to do a full assessment and develop a treatment plan as soon as possible. And once again, Maria will describe the clinical assessment for this particular scenario.
So our athlete has come to the clinic and for their clinical assessment. So I'll just make sure. Yep. So once again, we look at our history. We ask about the incident, looking at the mechanism of injury, and we've seen the video of how that may have happened. We need to be thinking then about doing our body chart, and we know that he's got an intermittent deep groin sharp pain that's 8 out of 10, and he goes from sharp into an ache. We also know that there are no pins and needles or numbness. There's no clicking in his hip, and he's got no pain in the lumbar spine, the other hip, the knees, and the ankle. So again, considering a differential diagnosis, we need to think about the area of pain and symptoms. So in this case, we're thinking about, the adductor muscles and the insertion, as well as the musculotendinous junction. Look at any underlying structures there that contribute to the symptoms, as well as any possible referrals. And then together with the history, we're looking at what is our hypothesis. And in this case, we're hypothesizing an adductor strain. So going back to then the adductor-related groin pain, the acute that we talked about before, we know it's common in sports and involves sudden change directions, as we saw, and it's most commonly the most commonly injured muscle is the adductor longus, as you can see here in this picture, and you can see that it can happen at the musculotendinous junction. And they'll experience tenderness and pain in the groin with palpation, as well as on stretch and contraction of the muscle. The clinical signs that we're looking for is pain on the muscle belly or the musculotendinous junction or on the inferior pubic ramus. And looking together, then adductor tenderness and pain on resistant adduction will give us a more conclusive diagnosis, with positive tests on resisted outer range adduction, positive squeeze test with the hip neutral in the long lever is more, it biases more the adductor longus, and a passive adductor stretch. If all three are positive, there's an 80% probability of a positive MRI in the adductors. So then if we know then that, we don't have MRI easily accessible, with our good clinical assessment, we can have an 80% probability of being positively able to diagnose an adductor longus strain muscle injury. And the problem, it's important to realize that the adductor strain can actually become recurrent and chronic and leading to a tendinopathy if it's not properly managed. And this is, with a tendinopathy, we know it's a gradual onset, and we know that the pain again will be experienced with movement activities. The clinical signs will be again pain on palpation, but also positive squeeze tests of 0 and 45. Now, this is not what our case scenario has, but it's important to be aware of it as he's rehabilitating, that he doesn't start to develop some of these symptoms. So then it's really important to also look at differentiation palpation. And as you can see here in this slide, are 4 different entities that we are looking at, and it's important to do a good but sensitive palpation. Once again, must remember our outcome measures, which are, these are the ones that we mentioned before, that are useful for athletic population. And then for the physiotherapy management, I'll just pass on to Mark, and he'll discuss the approach to managing and return to sport for our basketball player.
Thanks, Maria. So this table here illustrates very well a good approach to managing sports injury rehabilitation for a broad range of conditions, not specific necessarily to adductor-related groin pain or to hip conditions, but just outlines how we should be thinking as physiotherapists. We know the person has sustained an injury, and in the first phase, we want to think about what is the most appropriate acute management we can introduce. And we talked about that already a little bit when we talked about the police principle, and also avoiding the harm factors. And acute management will extend usually beyond the first 48 hours into the first week, and it can include other things, including manual therapy techniques. If there's joint involvement, it can involve soft tissue techniques after the first 48 hours. It may even involve modalities, though the evidence for the usefulness of these in some of these muscle injuries is not strong. But whatever we do in the acute phase, we're thinking right from the outset about the longer term goals for the athlete. So in the second phase, we want to start increasing the tissue tolerance, and we're thinking about mechanotherapy principles. In other words, how we can use exercise interventions to actually positively lead to improvement in tissue structure. And at the same time, we've got to ask ourselves the question, what may have been some of the risk factors that led to this injury in the first place, and are they modifiable? It could well be that there's things which have been present in this athlete for some period of time, and if we've done musculoskeletal screening, then we may even know what some of those were. But sometimes there may be some modifiable risk factors that haven't been found before, but through our assessment, we might identify those, and they may in particular be some of the biomechanical factors, and we can look at things such as limb alignment, muscle ratios, strength ratios, and also whether or not there's normative data for the strength required. And that's particularly important area of work in sport, to understand how much strength may be required for activity. And as physiotherapists, we've often learned about the Oxford manual muscle testing system, or the grading systems using up to a grade 5. But for athletes, if we can actually measure the load they can produce using either weights or even better dynamometry, then we can be much more accurate. In that second phase, and right from the start, we're thinking about maintaining their general health and well-being and making sure they don't lose the fitness. And so that means we'll think about some alternative training, and some excellent research work done by a lot of people, including Tim Gabbett and Michael Drew and others, has found the importance of not allowing people to decondition at all in this phase, because that is actually a major risk factor for re-injury. In phase 3, we want to start thinking about replicating sport-specific demands, and in the return to sport phase, we will start adopting more specific rehabilitation exercises that are exactly matched to what they need to do on the field of play. And again, we will then think about what else we can do to prevent re-injury. So what does that look like for an adductor-related groin strain? There's an excellent chapter in Bruckner and Kahn's clinical sports medicine book, which has been written by Adam Weir, Per Hermlich, and Christian Thorberg, where, based on research that those three authors have done, they have looked at those 4 phases as described in the general slide before, but with specific reference to adductor-related groin pain. So the same 4 phases of acute conditioning, sport-specific, and return to sport. And let's have a quick look what each phase says. So in phase 1, we want to protect the injured structure. So coming back to that optimal loading principle, we want to make sure it's not injured anymore. We want to control pain and inflammation with the modalities that we have available. And this may also involve simple analgesia as prescribed by the doctor. We want to maintain range of movement, and we want to make sure they don't lose the ability to effectively contract their muscles and activate them. But it has to be done with minimal pain. Now, minimal pain is interesting. In recent years, even over the last 2 years, there's been some studies which have talked about the fact that you don't have to be pain-free when doing these exercises, but you should not be exercising or producing pain beyond a level of about 3 out of 10 on the visual analog pain scale. But a small amount of discomfort in this phase is acceptable. That's a bit different to some of the principles before, which used to talk about exercising without pain. And you'll see more research about this, I'm sure. The other good thing about this particular program that's written by Weir, Homwick and Thorberg is that they describe the criteria for progression to the conditioning phase, or the criteria for progression to the next phase. So in phase 1, the next phase is the conditioning phase. So if the athlete is able to do the exercises with 0 or minimal pain, up to no more than 3 out of 10 for all the exercises, and that they can effectively activate their muscles during isometric contractions, which we can assess with our palpation or maybe electromyography, but our palpation skills are more than good enough for this. And that they have active hip abduction, which is at least 50% of the uninjured side, or if they have problems on the injured side, of what you had measured in your musculoskeletal screening, then they can progress to the second phase, which is the conditioning phase. Here we're focusing on tissue repair, and we want to progressively load not only the adductor muscles, but also the hip flexors and abdominal muscles using a combination of concentric, isometric, and eccentric exercises. But they're low load exercises. So we're going to be using 20 to 30 repetition max type exercises with a load that is appropriate for the athlete to be able to do lots of contractions with good control and no more than 3 out of 10 pain when doing the exercises. And if there's some suggestions for some suitable exercises for the adductors, hip flexors, and abdominals there. So adductors, you can do them side lying against gravity. You can do them standing with elastic bands. You can do adductor squeeze exercises. And the adductor squeeze is an important one as a screening tool and also a return to sport criteria tool, as well as a strengthening exercise. But the adductor squeeze, because we've got the different adductor muscles, you can do with a long lever, which biases more your adductor longness, and also with the hip and knee flexed, which biases more the shorter adductor muscles. And you can also use slide board exercises, and we've got some pictures of those to actually work the adductors eccentrically in a weight-bearing activity. And these have been found to be very effective in this sort of context. Hip flexor exercises, isometric hip flexion in different ranges initially, followed by concentric exercises where you can use bands or weights or pulleys for resistance. And the abdominals, crunches in supine, front rolling with a Swiss ball, so the abdominals are working in a more natural elongated position rather than in the crunches, and also modified planks can also be used. And here's a criteria for progression to the third phase, to the sport-specific phase, when the athlete can do all of these phase 2 exercises with 0 or minimal pain, and when they have active range of movement, at least 80% of the non-injured side, and adductor strength, at least 60% of the non-injured side. So 60%, this again is where dynamometry, or an actual measure of strength rather than an approximate value such as a grade 3 or a grade 4 is important when you can. So in phase 3, we're getting into the rehabilitation and return to sport phase. So we're thinking about sport-specific activities, and we're going to look at restoring endurance and strength plus neuromuscular coordination that's appropriate to the demands of the sport. We continue our progressive loading of the adductors, hip flexors, and abdominal muscles, but we're going to shift more to more concentric and more high load type exercises. So you can progress from your 30 repetition maximum to 20 RM and then progressing to 10 RM with loads and weights increasing as we go to the reduced number of repetition maximum. We can start running. We will start with straight line running, which won't put as much stress on the adductors. And the suggestion in this protocol is that ultimately we want to see the athlete being able to do 20, 50 to 100 metre runs, where within that run they do a 5 to 10 metre acceleration followed by a deceleration phase, repeating it through the whole 50 to 100 metres. And when they can do that pain-free 20 times, you know that they're getting close to being able to go to more demanding activities. But we also need to progress them to lateral running and change of direction running, and you can use zigzag running and figure eights and Illinois agility test and other sorts of tools. And also commence what's called the Copenhagen hip adductor exercises, and we'll look at these in a little while as well. But start at level 1 with only 3 to 5 repetitions on each leg. And here's our progression to the sport-specific phase: 0 or minimal pain with all the phase 3 exercises, active range of motion, close to 100% of the non-injured side, and adductor strength at least 80% of the non-injured side. So here's some of the exercises that are shown on this screen here you can use. So you've got your adductor squeeze exercises. You can use a football or a basketball, or but they're usually about the right size. So something that the athlete can actually squeeze. That's the long lever squeeze test there, shown in number A. And then you have the shortened lever with the hips and knees in flexion. So as I said before, these bias different parts of the adductor muscle group. You can then do the side lying against gravity, as shown in number C here, where the non-exercising leg is flexed out of the way so they can raise their leg against gravity. And that can be challenging enough even for uninjured people, and it also will demonstrate how much range they have. And if you want, you can even use as an outcome measure the distance from the toe to the floor. These are the slide exercises using either a slippery sheet or mat on a slippery surface, and there's other ways you can do those, but they're very good. And we can then progress up to the Copenhagen exercises as illustrated over here. And they're an interesting protocol. There's been more and more good publications coming out about hip and groin exercises generally, and that one, there is a recent one which shows some more exercise suggestions published this year. No, just next slide. Thank you. Oh, I think it's gone too far. Sorry, just having trouble. And then here's the return to sport phase. So we're focusing on maintaining the muscle endurance and strength, plus improving the neuromuscular coordination. And you can add in dynamic muscle exercises, different forms of resistance. The slide board exercises, it's suggested that they can do 1 minute side to side, repeated 10 to 20 times. That's a lot. And it's deliberately a lot because that mirrors the sort of demand that will happen in a sport where you need to do a lot of lateral movement for the period of time that they're going to need to do it. No point testing someone for 2 to 3 minutes and say they can return to a full basketball game or a full football game. And the Copenhagen adductor exercise can be progressed to level 3, and that's a very high demand exercise. If anyone's tried it, you'll know just how hard that is. And if they can do all these things, they can return to participation in team training, progressing initially from maybe a shortened amount of training from 30 minutes up to a full 90 minutes to represent what would be normal for their sport. And they should be able to do full training for 1 to 3 weeks before a full return to sport. The picture is repeated across many injuries. Too early return to sport leads to a much more likely chance of re-injury. So handing back to Maria.
So as Mark said, it's important then that we look at some of the criteria for progressing them from the different phases. And then, and this paper that was only published this year actually by Andreas Cerna is a very good paper to have a look at, that talks about the strongest predictors of a longer time to return to sport after acute adductor injury. And the predictors they found is that if they had palpation pain at the proximal adductor longus insertion, or a palpable defect over the muscle, where there was a tear, and or an injury at the bone tendon junction on MRI, they found for these athletes that the median days for return to sport milestones were, I think, to be clinically pain-free was 15 days. For complete control sports training was up to 24 days. And for first full team training was between 15 to 31 with a median of 22 days. So it's really important that we maintain, we monitor the return to sport, we monitor their pain, their palpation, tenderness, we monitor their ability to perform some of these exercises, as Mark said, pain-free, and be able to progress them safely, looking at, once again, optimal loading. So then for return to sport, and these principles will apply to any of our athletes, and this consensus statement published in 2016 from the First World Congress in Sports Physical Therapy, the IFSPT supported conference, really says that it's important for return to sport that we have a shared decision-making process. In other words, it's important for the athletes, the coach, the physiotherapist, the doctor, the strength and conditioning coach, all to be on the same page and make the decision together. It can be one being telling the athlete a different thing from the coach versus a different thing from the doctor or the physiotherapist. So it's a shared decision making. We can use specific battery of tests like we've discussed, such as hopping tests, symmetry index, strength measures, to look at then what might be, what stage they're at and if they're able to return to sport safely, looking at the workload, making sure that they don't go back too fast, too quickly, too heavy a load, or too many training sessions, the intensity of the training sessions, so that we can prevent re-injury. And also it's important that we account for the psychological aspect. In other words, is the athlete ready to return to sport? How are they going through rehabilitation? And at this stage, there's no clear consensus in the literature for return to sport criteria for different conditions, and that's where the research is actually currently being conducted in different conditions. But I would like to, I guess at the end, leave you with the thought that it's important that for an athlete to return to sport, they feel ready to return to sport. They feel confident about managing their injury, and they feel that they're able to then adequately prevent a re-injury. So we need to ensure then that the injured athletes are physically, psychologically, socially, tactically, and technically ready to return to sport. Because if they return to sport and they've got the fear that they're going to get re-injured, it's going to affect their performance, and they're more likely to get injured as well. So we shouldn't assume that the physical and the psychological recovery from injury will occur at the same time. It may sometimes take longer for the athlete to be psychologically ready than what the physiological state of their injury recovery is. So something for us to ensure that we consider, and if we identify our athlete needs to see a psychologist for further support, then that we refer them on as well. So that's where we wanted to stop. I did have some more slides if we wanted to discuss anything later in terms of clinical reasoning, but I think with our time frame that we've got, we are happy to answer any questions and to thank you for your time and participation.
Excuse me, Maria, how many
Thank
slide
you.
flow for clinical reasoning?
You can try.
It's about 7 slides.
Can you finish in 15 minutes?
Yes.
Okay, you can continue before question and answer, I think.
Okay, thank you. Okay, so so what we thought we would look at, if you've got conditions like our 2 case scenarios that we've discussed that are presenting with anterior hip pain, we need to think about the condition. What might be a cause that would predispose the athlete to that condition, what symptoms they may be presenting with, and what clinical signs they may be presenting with. So, and then look at the supporting and the negating evidence that we have for that particular athlete to support this condition. So our first condition here, if we need to think about it as a labral tear, well, labral tear will usually occur from repetitive or single trauma incidents. So we look Is there a mechanism of injury? Is there a repetitive loading occurring with the athlete? Are they getting their pain anteriorly? Is it deep in the joint? Might it increase with prolonged activities? They may also get referred pain in the buttock or down the anterior thigh. But the other thing the athlete will be reporting is intermittent sharp catching pain or clicking. They may have locking, giving way, and it's also maybe a gradual onset. Then we look at our clinical signs, the flexion, adduction, internal rotation test, which may be positive with a labral tear. We talked about the Thomas test and reproduction of the patient's pain and possibly the click. Sometimes the flexion, abduction, external rotation may also be positive with a labral tear. And then the best imaging for a labral tear would be MRI, because then we can look at the morphology of the injury and the severity of the injury. And from this, we see which ones are positive for our athlete, so that then we can look at this as one of our provisional hypotheses. The next one then that we would look at is the FAI syndrome. Again, it's an anterior hip pain. And we know the cause for that is the morphology of the cam of the pincer bone morphology. And it could be also associated with possible twisting and loading activities, especially a history of those in adolescent years. So then we need to look at the symptoms that our athlete is experiencing, the motion or position that they get in the anterior hip pain. Are they getting any clicking or catching or locking or stiffness? Do they have any restricted range of motion? Is there any giving way? And the clinical signs that we're going to see is that a negative a decreased hip internal rotation. The flexion, adduction, internal rotation test may be positive, but we also need to accompany that with X-rays and look at the head and neck offset. And once again, we're looking at the supporting and negating evidence from all of these for our athlete to make our provisional diagnosis. We mustn't forget osteoarthritis. Osteoarthritis is common in younger athletes, especially those that have had acetabular dysplasia or they have had previous trauma. So previous trauma with high impact activities can predispose an athlete to osteoarthritis. So are they getting anterior plus or minus lateral hip pain? Sometimes the pain with arthritis can radiate to the knee, but they'll also be reporting morning stiffness of less than 60 minutes. So then we're looking at our clinical signs of osteoarthritis, which would be a decreased hip internal rotation and flexion with stiffness. They would have positive flexion, abduction, external rotation test, and the SCAR or the quadrant test may be positive. They'll have hypermobility in the passive accessory mobilizations, but also on X-rays, we may see joint space narrowing and osteophytes. So once again, looking at all of this together, then we can look at our supporting and negating evidence for our clinical reasoning. Another condition that also our first case scenario may be experiencing is hip joint instability if it's been going on for a long time. So that could be attributed to either congenital laxity, such as connective tissue disorders, hypermobility, or it could be attributed to repetitive trauma, laxity from repetitive trauma in the capsule. They may describe feelings of instability, pain in the hip and groin region, plus they may be getting more pain with activity. And they may have limited hip range of motion, and that may be limited by pain. They may also have anterior hip pain with prone passive extension and external rotation, as well as hypermobility in the passive accessory mobilizations. Yes, I'm aware Max says there's a question. I think I'll just finish. This is my last one, and then we will go to the questions. And then the last one is really, we have discussed the 4 different entities of groin-related hip pain, the adductor, iliopsoas, inguinal, and pubic-related hip pain, which once again, we're looking at the activity and the trauma that may be related, as well as especially with the chronic ones, the tendinopathies, we're looking at increased training and loading. Where the pains may be experienced, tenderness on palpation, as well as our positive pain-resisted or stretch muscle and squeeze tests that we've discussed so far. And last but not least, we must also look at the possibility of lumbar spine referral. And it may be that you may have both a local hip joint problem, as well as referred pain from the lumbar spine. So look at lumbar spine pathology, because there's a close connection between the stability of the pelvis, lumbar spine mobility, and hip. Looking at the hip pain and the ache, the areas of referral, if there's referred pain in the lateral anterior hip, thigh or posterior hip, and looking also at lumbar spine and mobilized PAVMs and active range of motion and quadron as some of our screening tests. So this is just a very quick overview of, I guess, an approach to clinical reasoning by looking at some of the conditions, what may cause them, the symptoms the patient is presenting, the clinical signs, and then are they presenting with any supportive or negating evidence based on our provisional hypothesis. And this is just some of the references. So yeah, I think I'll stop sharing now and we can look at some of the questions.
One of the questions that was asked earlier, Maria talked a little bit about even in that slide a second ago. One of the questions earlier was how important is it for us as physiotherapists to train hip mobility for young aged athletes, and what will happen in the future if we miss that? Now, I think whoever asked the question was probably thinking about, do we need to work on increasing range of motion? Because that's a thing which is often talked about. But as Maria was just talking about a moment ago, we need to optimise range of movement for what is the best for both normal function and also sport-specific function. And it's not always just about increasing range. In fact, excessive range of movement might predispose people to injuries more. And also, stretching, which is often used therapeutically, isn't very effective at increasing range of motion in isolation unless it is only due to muscle tightness. And even there, you have to do a huge amount of stretching, which may only result in a small improvement. I think Maria may want to make some more comments about this as well too. But the other thing also with the hip, there's been some studies which have looked at the ratios of the ranges of movement, particularly with external rotation and internal rotation, and that it's if a person has a good total amount of range, but the bias is more to external rotation or internal rotation, and it's not, then they may still be more at risk, or it may actually represent that they already have some of those particularly impingement type related problems. But I'll pass over to Maria, who probably will give some more detail on that.
I think the important thing to know, thank you, Mark, the important thing to note with the hip is that we've got the two femoral heads, and we've got to balance our entire trunk and our entire, upper body on those two femoral heads and transfer the weight through to our lower limbs. So it's important to have a balance between stability and between control. We need to have dynamic stability and control, and we need to ensure then that both the passive structures as well as the dynamic structures, like the muscles around the hip, are in their optimal performance to be able to allow the athletes to transfer some of those movements and some of those forces from the trunk through to the limbs to be able to be effective with their sport skills. So as Mark said, it's really important to look at the requirements of the sport. And within the sport, we'd look at whether flexibility, so it'll be different a requirement for a gymnast, for example, versus a requirement for a soccer player. However, if we're addressing mobility, or if we're addressing range of motion, we must do so with also looking at the dynamic control simultaneously. We can't look at range of motion at the expense of stability, because that's when we're going to end up leading into problems and injuries. Excellent.
Mark, Maria, there are some questions in the screen. Would you please answer, please?
Yeah, thank you. So Maria's just answered the first question there that we saw. I picked up a couple of them, and I did answer a couple in the chat. I did speak briefly about the importance of the biopsychosocial aspects in athletes in particular.
Can I add something to that?
Do.
So the other important thing with the biopsychosocial aspects, yes, we talk about the psycho aspect and about the athlete's readiness to return to sport. But I had one of my students last year that was actually looking at the social aspect. And it's really important when we're looking at lengthy rehabilitation and the athlete is no longer training with their teammates, they may be feeling very isolated. They may be feeling like they really don't have their support network around them. So it's really important that we also find out what the social support network is that they have to support them through an injury rehabilitation, to ensure that, you know, they may go to training, but not participate in training, but do their exercises. Socially, they're still part of the team. They're still feeling connected with their teammates and feeling like they'll have a place and an identity when they return back. Otherwise, a lot of the athletes may end up losing some of that identity and they may lose their purpose, which can then further hinder and slow down any rehabilitation. So we need to look at the bio, yes, the physiology, the psycho, yes, are they ready, how are they feeling, but also the social support network that they have around them and their identity. So I hope that answers that question.
Okay, the next from Alfian.
Yeah, this is a good question, and it's one which is difficult or simple, depending on a bit on the pain the patient has. There's been a lot of work done trying to calculate, to work out if you can calculate what your starting load for training is. I don't know that research work very well, and when I read it, I see a lot of mathematical formulas, and including sort of algebraic approaches using logarithmic functions and other things. And I'm sure that one day someone's going to give us a really good formula. But the majority of the time, you want to start with an exercise they can do now with not more than 3 out of 10 pain. Now, we used to say with 0 pain. Now, the trouble with 0 pain is that can be almost no load. And even with no load, there may still be pain. Where we introduced the concept of allowing some degree of discomfort, which is now well supported by the research, it means that we can fairly quickly work out what the person can do. And it might be that we're using, for example, in the case of a hip internal external rotation exercise, we might be using an ankle weight, and they might start with a 0.5 kilogram weight, and they can do that without no pain or 1 out of 10 pain. We go to a 1 kilogram and they can still do that. We go to 2 kilograms and they're saying that's about 3 out of 10. So that's going to be the load we use then. And from there, we normally will then think of some of the principles that have been suggested for regression, including not increasing by more than 10% at a time. Though that model or that concept, there's some people who think that's not as reliable as we're used to, but I still find it's a fairly good approach, which is, it might be on the conservative side, but if we want to add more than 10% increase each time, and sometimes we have to, because if we're using pulleys or dumbbells or whatever, we can't add 10% very easily. It might be having to go up a bit more than 10% at a time. As long as we keep working with that 3 out of 10 as the guide, then we're pretty safe, both with respect to the literature and also what we're observing in clinical practice. So I'd say that is a simple approach, but I do think we're going to get better guidance with some of these very clever researchers as they do some regression analysis on what worked and what didn't. Once again, Maria might want to add to that. Nope. Maria's happy with that. So
happy with that.
Okay. Next question, please, Sakra. Okay.
So I answered that one in the chat.
You can choose.
Yeah, what are the criteria for injury to players who continue the game but cannot continue when the game is in progress, and how to judge it? So generally we use the combination of the stop and the toe tap principles that I described before, in particular the skills test. The most important thing to know is, once we've established that the person isn't in immediate danger, so they don't have a life-threatening condition or that continuing isn't going to cause significant escalation of their problems, can they do what they need to do to be effective on the field of play? And this is where sometimes if you've got a star player, the coach would be happy to have someone who's only 50% as good as normal because they're really good. But if they can't move, then obviously they can't continue. If they can't move effectively to do their role within their sport, then they probably shouldn't be continuing. And particularly if they have either high levels of pain or based on their history or observation, it suggests a traumatic injury that will be made worse by them continuing, then they shouldn't. So the skills test is a bit of a black and white. Can they do it or can't they? If you're using the skills test alone, it's either they can or they can't, and if they can't, they're off. If you want to consider, though, sometimes that athletes may be able to do the skills and they can do them even though they're actually making themselves worse because they've got very good levels of pain tolerance or the adrenaline is keeping them wanting out to play, you still should think about whether or not they're going to harm themselves more by continuing and either overrule them if that's your role or suggest to the coach they don't continue if you have to make that decision in collaboration with the coach. Number 5, from Surya, is it important to assess the equality of adductor muscle strength between injured and yes, absolutely. And this is true for many, many conditions now, but we know that we need to make sure that people have both normalised strength and endurance between the two sides, and a principle of not more than a 10% difference is sometimes applied. And then the other part of that is not only is it equal and enough? And enough depends on whether or not there's normative data that has been published. And for some conditions there has been, and I don't know all of them well, but there was one study which looked at adolescent Australian football players. Australian football is a bit like rugby, but a bit more high speed. And they found that players who were aged between 16 to 18 who couldn't do an adductor squeeze test using a blood pressure cuff, if they couldn't do more than 180 millimeter squeeze for 30 seconds, they were much more likely to get injured in the forthcoming season. So equal and enough. So yes, absolutely.
I think that leads to the next one too.
How can we be sure that the pain scale 3 out of 10 athletes say is still safe or not for the conditions? Well, that sort of goes back a little bit to when we use the pain scale, and we have to trust that the visual analog pain scale has been validated as having internal reliability. So 3 out of 10 for that athlete, if they're accurately reporting it, is what we're firstly trying to establish. Now, in sports, sometimes people will tell you that they have no pain or low pain when in fact they do, because they don't want to not get picked for the next game or whatever or it's a big game coming up. This is challenging, but hopefully through our ongoing work with coaches and athletes, and as they come through the development ranks, they understand the importance of accurately reporting and that that is in their best interest. A similar discussion has happened in the concussion debate, where athletes used to hide their concussions, but now because of good player education, they understand that it is very bad for them to do that. So people are more likely to report to you truthfully what their actual level of injury or dysfunction is. And similarly with the pain scale, they're more likely to tell you it's 3 out of 10 if they understand that if they're not giving you the full information, it could have career-threatening implications, and that they might get through the next game, but they mightn't get through the next season, and they mightn't get picked at all the following year. Is there another way beside pain perception that we can use? Yes. And Maria was going to talk about, well, I'll pass to Maria in a second, but you can use strength and or range, but strength in particular. Once again, if we know there's normative data for a particular muscle within a particular sport or age group, if they can't get to something approximating that normative data, then we would not let them return because they haven't got enough strength. And also when we talk about strength, it's not only that power ratio we measure with dynamometry, do they have enough endurance? Can they reproduce that muscle activity long enough for the demands of the sport? And Maria, I think we'll add to that.
Yeah, I agree with Mark, and I think the other things that we can also look at is whether the pain is actually resolved very quickly after they've done the exercise. So if the pain lasted to the next day, past 24 hours, then there's a sign that probably they're not ready, or they may be causing more damage. So you need to back off. And then the other one is, don't forget, as I mentioned before in some of the previous slides, you've got to look at the palpation and see if there is any tenderness on pain of the muscle, and also look at pain on resisted as well as stretch contraction, resisted contraction or stretch of the muscle. And there are other criteria, as you can see, that you can look at, which is what was used in that study by Andreas Cerner as well. And I think that probably answers a little bit more about the coping method when the athlete is moving or doing exercise after injury of a duct or a muscle. So I guess looking at the symptoms they're experiencing, but also what must we pay attention for the movement in common. So you may need to be looking, if I understand the question correctly, looking at the way they're doing their exercises, looking at the form of their exercises, that they've got good alignment between the hip, the knee, and they're not loading the adductor muscle more, and they're able to also have good trunk control as they're cutting and turning. And Mark may want to add to that as well.
We've got another question which has come up in the chat.
And one more in the next slide, I think.
Okay, next slide, Chakra. The other number 8, question number 8, Chakra, please.
The last.
Number 7 last.
Number 7 last.
Okay.
Oh, there's the last one. There's another question in the chat which says,
Yes.
how do we differentiate FAI, groin hip injuries, from inguinal and varicocele hernias? So Maria will probably better answer this one here, but I mean, this is where sometimes we may need to think about involving other people in the medical team who may have more knowledge of conditions which represent more medical or surgical presentations. But we know about some of the things, like if they have pain on cough or sneeze or Valsalva, then that would be more suggestive of an inguinal hernia. So we have to sometimes correlate our findings. Palpation is another thing that might help guide that as well too, and also the patient history. Maria?
Yeah, and as I agree with Mark, and as I mentioned before, in the for the FAI syndrome to be a diagnosis, you need to have 3 things. You need to have symptoms, you need to have positive clinical signs, so the symptoms of anterior deep hip pain. You need to have pain on the symptoms, presenting symptoms of pain with, say, adduction, internal rotation. You may also need to have positive clinical signs. Your flexion, adduction, internal rotation can be used to rule it out. But to rule it in, if it's positive, then you also need to go to X-ray to look at the cam impingement, the cam morphology. And if they've got cam morphology, positive symptoms and positive clinical signs, then that's your diagnosis of FAI syndrome, versus then looking at other imaging that might be required for looking at hernia. You might go to ultrasound, for example. I hope that answers that question.
Okay, any question from the audience? With Mark and Maria, we still have maybe around 25 minutes. It's possible if any question by the audience.
Oh, okay. I didn't realize. That's good that we've got 2 hours in total. I thought it was 1.5.
Yes, is there any question from the audience directly? You can raise hand or unmute your microphone and just give the question. If there are any question from the audience, please. Kalau ada pertanyaan dari peserta, silakan yang mau langsung bisa langsung matikan unmute mic-nya, kemudian silakan bertanya.
I really like the comment. Thanks, Mommy and Papi Aussie from Jatmiko. Thank you. That's very cute.
Yes, you are our mommy and papi from Aussie. Okay, I may I ask something, Maria and Mark? I
Sure.
just want you to explain more the process from the return to participate and return to sport and return to perform. How we make a decision for that time of process.
Yeah, thanks, Andrew. The answer to that is, in some cases, there are more clear guidelines than others. So with the adductor-related groin pain, that chapter that I've summarising from Bruckner and Kahn, it summarises in turn many other research studies, and based on those research studies, they've come up with those suggestions that it's a very progressive approach, but ultimately that we need people to show evidence of having the neuromuscular control, from the physiotherapy perspective in particular, the neuromuscular control and also the muscular strength and endurance to do the activities related to the sport, and that they need to be able to do them under sports conditions, and they need to be able to do it for a satisfactory period of time that mirrors the demands of the sport, and they need to be able to keep doing it over a period of time, not just on one particular day where you do a test. And I think that last part's a big difference, because in professional sport, a lot of times you often, even if you follow sport in the media, you'd see that the medical staff are going to be putting the injured player through a testing session, one session. And now I think what we're seeing from some of this research is that one session, a person might get through, but how are they after that session? You know, within the next day or two, they'll be going through a recovery process. And we don't know how they're going to be after a couple of days. And maybe they get cleared to play at a training session on Thursday, and then they have a game on Saturday, but they haven't fully recovered by Saturday. So in other words, they're still likely to get re-injured. So we should instead be looking at those testing sessions or the testing or progression criteria on a repeated basis. So that's why that suggestion was in the slide there, is that people should be able to do close to normal activities for close to the normal time according to the demands of sport for 1 to 3 weeks, not just one day. And I think that's a really, really good point. It's similar to some of the research around ACL rehabilitation as well too, and that as people probably are increasingly aware, many people who come back even a month or two early are much more likely to have an injury and actually waste all of that time. This is where good communication though with the coach and the athlete, and we understand that they want to get back to play, and we understand that the coach might have other players injured and they really want this person to come back. But if they've had an injury and they've been out for 6 to 8 weeks and they want to get them back 1 or 2 weeks too soon, then we're talking about another 6 to 8 weeks or even longer. So it's important to communicate those principles. So I hope that adds a little bit further, Indra, to what you were asking. But if there's anything else, please see if I can clarify it.
Thank you, Mark.
In the case of the LeBron James one, by the way, as we took thinking about this, we didn't talk too much about LeBron James specifically, but I looked up a bit about this, and by the time that injury happened, he's already in his mid to late 30s, but he had never had many injuries. He'd had a very good history of being able to play most games of the season and not be out for very long. But since that particular groin strain, he's had ongoing injuries, groin injuries, and over the last 3 years, he's had more time off. Now, he is an older player, and age is a bit of a risk factor for muscle injuries, even when you've got good strength. But as Maria mentioned earlier, there's a fairly high likelihood of progression to tendinopathy. In other words, a compounding of the problem. The acute muscle strain may lead to adaptive movements and also changing load patterns, as well as tissue damage. So you can get a secondary problem on top of that. So that makes that return to play decision even a bit more difficult when you've got players that are more towards the later part of their careers, because it might even be that there's an indication they're getting close to not being able to do what they used to do, and they might be used in, say, in football more as a player who comes off the bench in the later part of the game rather than someone who's going to be there for the full 90 minutes. Once again, these are things that those of us who love sport will be interested in, and we can consider and make recommendations to the coach. But from from what we know in the literature, we have to think about what we can tell about the level of tissue recovery. And unless we are doing repeated MRIs, which they do in some high-level sports where there's a lot of money involved, then we have to be guided by our clinical findings, and strength and range and endurance and neuromuscular control are the main things that we're going to go by.
Is there any question? Please, Ardi, you want to ask something? No? Okay, back to you, Cakra.
Oke, Pak Indra nanti ini informasi buat, oh ya, ini ada from Faisal. Wah.
Mark, Maria, sorry, there were questions from Faisal, please.
Maybe able to add 2 more questions.
I'm just having a look.
We have 2 more questions.
Okay, yeah, quadratus femoris is interesting muscle. So the question is, could you explain more about the relation of quadratus femoris muscle and hip injury? Because I got this knowledge from Amir Takla that last year came to Indonesia, and thanks to him, we tried and have a great result. So quadratus femoris is a very interesting muscle, and it's actually thought to be one of the low load stability muscles of the hip. It's behind the hip joint, and it's actually thought to provide more anterior posterior stability of the hip joint. It has slow twitch muscle fibers, and so with pain and injury, it's thought that it would atrophy a little bit like the BMO muscle is for the knee. So if, as I mentioned before, we've got the 2 femoral heads, and we've got the acetabulum that in some people can be shallow, that needs to stabilize and provide support, for those joints. So we really need to rely on those muscles around the hip. So quadratus femoris provides, it's a low load muscle that is active quite throughout the movements, not just in external rotation, to provide that anterior posterior stability. And in fact, if you can palpate a lot of, the quadratus femoris can be quite atrophied and almost like a gap in the over the muscle bulk compared to the other side in someone who's been experiencing hip pain. So there are some physios, and I've tried that as well, and it works really nicely, but to where you can use motor control retraining to activate the quadratus femoris muscle. And sometimes that can be used also guided with real-time ultrasound to be able to then provide more stability around the hip joint. It's only one of the muscles that provides stability and support. You've got to look at your deep external rotators in total as well. You've got to look at your gluteus minimus and medius, so your hip flexors. So all of the muscles are going to be important, but that's one, specific point about quadratus femoris. And that with hip pain, you will get atrophy, which can then predispose them more to hip injuries as well, or instability. Does that answer your question, Faisal?
Teman-teman, saya rasa sudah cukup ya untuk pertanyaan hari ini. Untuk pertanyaan pada...
Satu lagi dari Ardi Bimantoro, tolong dijawab. From Ardi, Maria and Mark, in your experiences, how longer it takes recovery from rehab phase to return to perform in adductor injury? It seems based off our criteria basket. Thank you, please.
Well, I can answer based on the study that I was mentioning before by Andreas Cerner, where they found a median time of about 22 days. For return to sport in depending on the level of the injury and depending as to whether they've been able to have pain-free palpation and no palpable palpation deformity at the muscle. So I think it's really important that you look at some of those studies that have looked at how long it takes, depending on the grade of the injury and the symptoms that the athlete is still experiencing. Unfortunately, I'm not familiar about Derek Rowe's return, so I'm not sure. But if he took a long time to come back after an ACL injury.
I could talk a little bit about it.
Thanks, Mark.
I could talk a little bit about that. So it's ACL injury, but it's even though that's different to what we're talking about the hip today, sometimes people don't follow what you expect in terms of their recovery pathways, and certainly when surgery is involved, then that adds in another level of complexity as well too. With that ACL type one, it will obviously depend a lot on the severity of the injury and whether or not there's other factors such as avulsion fractures and whether or not it's an isolated ACL injury, if it's also got meniscal pathology and other factors as well, and on the player's biomechanics. But haven't followed that one closely, but from what I understand, it was not seen as being a complicated surgery. It was supposed to be a good outcome, but he came back in. It was a pretty short period of time. It was certainly well under the 12 months when they tried to start doing the change of direction type training. And I don't even know if he actually got back onto the court, but they started trying doing some of the cutting and change of direction exercises pretty early. Now, sometimes for elite athletes, that has been the experience that people can do it and get away with it. But increasingly, the evidence is that you shouldn't progress people unless they're hitting key milestones. And there's some very good sort of summary of some of this information that's published, and one of the ones is using things like the single leg rise test, for example. So whether or not you can do a single leg rise from either a chair or a bench that is at the height of your tibia, and you should be able to do about 25 of those before considering any sort of return to sport. Now, many times people aren't using anywhere near that sort of volume to determine whether or not people should progress. And even there, you can still have, as someone else mentioned earlier, the psychosocial factors. And this is another huge area to this, is that sometimes people can do all of the things in a gym environment or a clinic environment or even a training environment, but as soon as they go back into a situation which reminds them of the environment they were in when they suffered the injury, their attentional focus might not be in the right areas. And there's some really interesting research which sort of goes between physiotherapy and psychology, where people's eye focus changes after injury, and also it overlaps as well with their fear of movement or their perception that they're more likely to be injured. So not everyone has the same experience because there's some other factors as well. There's some interesting research and exciting research being done using virtual reality to train people to being in almost identical to on-field or on-court experiences, where you have virtual players that they're seeing through the goggles while they're actually doing sport-specific activities, and sometimes they're instrumented to measure their muscle activity as well as their eye movements, and it gets very, very high-tech. Things which are outside of what most of us can do in our normal day-to-day clinical lives. But without knowing exactly all the details with Derek Rose, there have been some people who have not done as well as others, and some of the factors I talked about that might explain some of them.
Baik teman-teman, saya rasa cukup ya untuk pertanyaannya.
There's another question I can see there. How about that snapping sound? Is that related to FAI? Snapping hip syndrome could occur for a range of reasons, and Maria will be able to tell you all about those. But iliopsoas is another source of that. But yeah, Maria will answer that.
Yeah, so no, Mark is right. Iliopsoas is one of them. So the snapping sound, let me see the question. Yeah, so there's a snap you can get. The important thing with the snapping sound is you've got to differentiate, is it a deep internal to the joint sound or is it a superficial? If you're getting a snapping or a kind of sound or a clicking or a popping and it's deep in the joint, then you're thinking more about your intra-articular structures. So then it could be possible that it's a labral tear or associated with ligamentum teres instability. But if it's a more anterior snapping sound or feeling and you can palpate it, it could be the iliopsoas tendon over the iliopectineal eminence as you're going from flexion eccentrically towards extension. If the snapping sound or feeling is on the lateral aspect, that could be the iliotibial band as it's moving over the greater trochanter with flexion and extension. So in either case, you've got to identify, ask your athlete where they're feeling it, if it's deep in the joint or if it's on the more superficial, if it's more part of that clinical reasoning in the body chart, if it's anterior, if it's lateral, and then look at some of the tests that to look at reproducing it. And quite often, say for an iliopsoas snapping hip and the anterior snapping hip syndrome, which is the iliopsoas tendon, you can sometimes put pressure on the iliopsoas tendon, get them to flex and then eccentrically extend the knee. And if it takes the sound away, the feeling away, that's also another way of confirming the possibility of the iliopsoas tendon involvement. It can become painful if it continues on, but in more cases, it could be painless and it could also be bilateral. But we need to look at, again, a good activation of the muscles around the hip to provide control and stability. So you're not getting overactive muscles in one area, which might be then producing some of the predisposing factors for some of that snapping sound. And I hope that's answered the question for Jatmiko.
Yes. Oke. Sudah ya, Pak Indra?
Sudah. Silakan.
Oke. Baik, teman-teman, saya rasa sudah cukup. And then, before I close it, thank you for all of the presenters. And I think the all of audience is really, really satisfied with the answer. And then, finally, we are come to the last agenda. We would like to say thanks again for presenter and all of the audience for active participation. And hopefully the presentation will give benefit for us. And thank you for your attention. Thank you for all presenters. Thank you for sharing your knowledge, experience, your insights. God bless you and your family, and see you next time. Thank you.
Thank you very much, Chakra, and thank you everyone for your time and for your attention. And we hope you all stay safe and well until we meet, and hopefully we meet in person next time. And I hope through today we've been able to, through using the two case scenarios as examples, been able to look at some of the complexities of the assessment, the diagnosis, the management, and the return to sport of hip and groin pain in athletes. And using a clinical reasoning approach, then we'll be able to then look at different conditions as well. So I wish you all the best in your future endeavors, and I'll pass on to Mark to say his goodbyes too. But thank you, Indra and Chakra and Rashid and everyone, and we look forward to seeing you in person soon.
Thank
Bye
you,
from me.
Maria. Thank
Thank
you.
you, Maria.
Thank you very
Bye-bye.
much.
Thank
I see you next
you.
year ya. Oke teman-teman, dengan berakhirnya materi dari Mark dan Maria pada siang hari ini, maka berakhirlah seluruh rangkaian acara webinar fisioterapi olahraga online pada yang gelombang pertama. Jangan lupa kita akan ada gelombang kedua di akhir Juni ini dengan materi khusus mengenai cedera olahraga dan akan diisi oleh beberapa pakar seperti dokter sport, dokter ortopedi, ahli gizi olahraga, ahli psikologi, dan kita juga akan datang tamu dari Brazil, Luciana de Michel yang akan menyampaikan tentang preventing of injury in Indonesia. Once more, thank you Maria and Mark, and see you next year in Indonesia. You always be our family. Love you all.
Thank you.
Yeah,
it's been a pleasure. Thank you all for your nice comments. We look forward to it next time. Bye now.
Jiwa.